This summarizes the links between the cause and effect of the systolic shift of the echo wave. The cause is an increase in pulse wave velocity, and the result is insufficient myocardial perfusion. But what can cause this increase in pulse wave velocity? First is arteriosclerosis, which decreases the elasticity of arterial walls. This develops slowly, progressively, and silently due to aging. Second are increases in blood pressure, which increase the tonus of the arteries. These increases in blood pressure may develop suddenly and rapidly due to exercise or emotional stress. After a large enough systolic shift, due to the combined effect of arteriosclerosis and increases in blood pressure, a threshold is reached, above which symptoms of myocardial insufficiency appear, and cardiac function can break down rapidly. In the young, there is little arteriosclerosis, and therefore minimal systolic shift at rest. Increases in blood pressure due to exercise or stress may produce additional systolic shift. In the young and healthy, there is a large amount of cardiovascular reserve, even in the presence of vigorous exercise or severe stress. After a certain amount of aging and a higher level of arteriosclerosis, systolic shift is increased significantly, even at rest, and even more so when blood pressure is increased due to exercise or stress. This results in a marked decrease in cardiovascular reserve. In later stages of aging, cardiovascular reserve is further decreased and is adequate only at rest, but not during exercise or stress conditions, when increasing symptoms of coronary insufficiency start appearing. This is what the usual photoplethysmographic tracing of the arterial pulse wave looks like. After transformation, this is what an APGram pulse wave looks like. It now contains at least 5 distinct peaks. The A peak is related to the force of contraction of the left ventricle. The B peak is related to cardiac output. Peak E corresponds to the closure of the aortic valve. Now let's superpose these two tracings. Peak E matches the dicrotic notch. Peaks A and B are associated with the leading edge of the primary wave, which is due to ventricular contraction. But what about peaks C and D? The answer is that they represent the leading edge of the other wave, the echo wave. Could you slip this over the middle finger of your right hand? Okay. And hold it at heart level. That's good. Now, if you just close your eyes, relax, and keep your hand over your heart, this will take only a minute or two. The top band contains the classical plethysmographic recording. The middle band contains the first derivative, or the velocity plethysmogram. The third band at the bottom contains the second derivative, or the acceleration plethysmogram. This is the APGram recording on which all our calculations are based. Let's look at the data we just obtained. First, we have superposed the 60 heartbeats. You can see some small variations, even in this healthy young man. Let's put the data in motion. It's also possible to look at these heartbeats by using a three-dimensional display. Let's put this in motion also. Then we display an average of these 60 beats along with the standard deviation for each of the time points. The calculated APG coefficient is plus 75, which indicates a large cardiovascular reserve. There are also 7 more graphs and tables of information generated by this test. It is clear to us that we should consider performing an APGram routinely whenever we measure a blood pressure or run an ECG test. If you want to incorporate APGram testing in your research programs, we will do what we can to assist you.